move the journal forward. The conference edition of the journal, as I speak with you, is ready online. You can access that. We're not able to print the hard copies. I'm sure maybe the ESCO would print it and disseminate it to states, a few hard copies for the individuals to have a copy of it. Thank you.
Please, can we have another round of applause for the presenter? Okay, before we call on the next presenter, there's an announcement here. Please, if you're a member of the ESCO, the National Executive Council, and here in the hall, you're called upon for a brief meeting at the Executive Hall outside. Please, all members of the ESCO who are seated here in the hall, proceed to the Executive Hall for a brief meeting. All right, on that note, we're going to take the second oral presentation, and the topic is a qualitative study exploring the experiences and the factors that influence use of low vision aids in Lagos State. And to make the presentation is Dr. Omojeme Esther Adomi of St. Edmund's Clinic and Eye Hospital, Lagos State, Nigeria. Please, a round of applause as she takes the podium.
Thank you. Good afternoon, everyone. I stand on existing protocols. Thank you for the opportunity to present my paper. So I'll start with a short story before I start the slides. So I got into optometry because I was interested in vision. Right from a young age, I've had very poor vision. Without my glasses, one of my eyes is about 160, and the other one is about 260. So I wanted to know why. Why is it that my vision is poor? And in filling the JAM form, I filled optometry. And my dad was like, what is that? And he texted it. But God being so faithful, it happened that despite all that, I got into optometry. And in the course of my career of about 15 years, I've been able to help people improve their vision. But I found out in the course of my career that there's a group of people that, despite surgery, despite the use of glasses, despite everything, their vision just wasn't improving for one reason or the other. And I got interested in the field of low vision. I still remember a conversation I had with one of my patients, he's a professor, and he was like, so after everything, all the surgery, after everything, glasses, all that I have done, he has done like 2 surgeries on his eyes, he has advanced glaucoma. He still is not able to read. And you can imagine, if you are the kind of person that likes to read, I love reading. I can't imagine how it is for someone that loves reading not to be able to read. And they'll tell you, sorry, there's nothing we can do. So I got interested in low vision, and I went for a couple of courses in it. And I started practicing. And I found that even in that cadre of people, even after giving them devices that helps them to read, that helps them carry out activities they couldn't carry out before, they still were not using these devices. And it got me curious, why? And in my master's program, part of my dissertation was this paper, and it brought certain surprising findings to my notice. Some were expected, but some were quite surprising. And I decided to share it with my colleagues, with my co-optometrists, those of us that practice in low vision, and even those that don't practice in low vision, to help us guide how we help these patients. Because it is one thing for you to prescribe for a patient, it's another thing for that person to actually use those devices. Please, next slide. So we'll start with the basic, which is defining low vision. Low vision is an impairment of vision. Even after treatment, after everything has been done, the person's VA is still 618 or 10 degrees. But found out that in low vision, with the use of low vision devices, these persons were able to use this, their residual vision, were able to help these persons. Next slide. The statistics of low vision in Nigeria, as Dr. that presented earlier on, and what another doctor mentioned, most of us are still relying on our National Blindness and Visual Impairment Survey that was done in 2005, 2007. But that is all we have for now. And I hope that, this kind of collaboration, this kind of talk, like what Dr. spoke about, we can do something similar. But based on those data that was done, right now, the leading causes of low vision, 40 years, among people that are greater than 40 years, are cataracts, glaucoma, and corneal opacity. And the risk factors include being male, living in the Southeast zone, increased age, and being unmarried, and living in the rural area, and illiteracy. All these are based on that visual impairment survey. Next slide. Also, worldwide, we have over 250 million people who are visually impaired. In Nigeria, we have a prevalence, based on that same survey, of people greater than 40 years of about 3.5%, giving about 3.1 million individuals in that same age group with low vision. So it goes to show that low vision is not something that is restricted to just a small group of persons. It is quite significant for you to have, as at then, when this study was carried out, 3.1 million persons with low vision. Next slide. So, health impacts of low vision. What are the health impacts of this low vision? I found out that persons with low vision are more prone to have falls, fractures, injuries, and also have mental health issues like depression and anxiety. I'm sure you've seen patients like that come into your clinic, like the professor I spoke about. They also found out that these persons with low vision, they have a poorer health-related quality of life compared to people that are diabetic, compared to people that are hypertensive, people that have chronic illness. They found out that persons with low vision have a poorer quality of life compared to those individuals. Next slide. Also, apart from having the impact on the individual, what low vision has, the impact on the individual, we also have the economic impact, the impact on the nation, because so much is being spent, first of all, on taking care of these persons. For example, in a household where you have someone that has low vision, that individual has to have someone taking care of them, doing stuff for them. That person that is taking care of them maybe normally would have gone out to work and make money and have an impact on the economy and on the family. But that person, because they have to care and have to serve that person that has low vision, his economic impact is reduced. He's now reduced to someone just helping a person out. Meanwhile, if this person with low vision has had the means to take care of himself, would have had someone released into the society to be able to contribute economically, not just to that family, but even to the economy of the country. And so these are the amounts of money they have calculated that are lost because of persons that have low vision. Either the amounts of money that is spent on them, some of them is the amount of money that would have come into the economy if they were, let me use this term, economically viable persons. Because once your vision is not good, once you are low, you have low vision, you are visually impaired, there is a limit to the things you can actually contribute to the economy. Next slide. Also, what are the benefits of these low vision devices? We have found what is the impact of someone not using them, not having them. What are the benefits? They help people improve their reading speed. It helps them become more independent. Somebody that normally will have to get someone to read for them, they can read by themselves. As I said, freeing up someone else to do other more economic viable activities. They are also able to interact with persons. Because there's a kind of, as I said in the previous slides, there's this depression. People that have low vision, they don't want to go out. They're just indoors. Because what am I going out for? If I go out now, let me not go and fall. Or if I go to church now, how will I be able to read? I'll just be. So these are the things that by the time the person starts to use these devices, it helps them in these areas. But the funny thing, as I said earlier on, despite these benefits, these persons still don't use these devices. And it's very common in developing countries. So this is a literature review. So before I started the study, I had to go and find out what has studies been done relating to this topic I want to address. And as Doctor said previously, there is a serious lack of data in Nigeria, and not just even in Nigeria, in Africa. And so in carrying out my study, I found it very difficult getting papers either conducted here or even papers conducted in Africa. So at a stage, I had to expand my view. I had to go to not just low-income and middle-income countries. I had to use some higher-income countries. And so, please, can you go back to the previous slide? Okay, so the other one too, next to that. So this had to do with the factors that influence low vision aid. So a systematic review found that the main barriers to the use of low vision devices were privacy, ease, whether it was suitable for use, and perception of stigma of using these devices, fear of independence, and lack of training were significant barriers. But funny thing is that the least concern was feeling of embarrassment, autonomy, and dignity. This was what these people found in their own study. I think this study was conducted in Turkey, if I remember. This was what they found out, that this is the reason why people were not using these devices. Next slide. And also, apart from just using it, complying with use of it. So they found out that what were major contributors to making people use these devices were familiar and external networks. The fact that their family encouraged them was a very significant driver to the use of these devices. And also, in the other study conducted by Smallville, they found out that because the person's vision progresses, in low vision, they found out that the visual loss most times progresses. They found out that the device is just limited. For example, the person might be having a VA right now of 660 or maybe N24, and that device was created for that time. And gradually, as time goes on, the vision impairment increases and the vision worsens. So the person can no longer use that device even when the visual impairment has increased. So they just drop the device aside. Next slide. And so the question that's been asked, what are the experiences and the factors that influence the use of low vision devices among persons with low vision? And the aim of the study basically was to find out what are their experiences, what are the factors that influence their use. And as I think a speaker has mentioned it, that a lot of these our studies, they don't have, clinical implications. So they are just for research. But this is my particular study because I'm a clinician. I was interested in how will I take the results of this study and put it into my clinical practice. And so what are the recommendations we would advise so that instead of the current approach of recommending these devices that we're using right now, what can we adjust in what we're doing? What can we do to make people actually use these devices? And what are the strategies we can come up with to improve the compliance of these low vision patients in using these devices? Because the current approach of recommending low vision devices, first of all, is based on the person that is doing the low vision assessment, first of all, your clinical knowledge. You've carried out the test. You say, oh, this person needs magnifier. Oh, this person needs telescope. The other factors, which we will address at the end of this, are not even being considered. And using those principles is not working. People are not using this device. They will collect it, they will get home, they will drop it. So that current approach of using your clinical knowledge and your own personal recommendation is not working. They are not using those devices. Next slide, please. All right, so and in this particular study, most studies that are conducted are done quantitatively, but I decided to go qualitatively because, first of all, when it comes to experiences, people's perception of things, you cannot put figures to it. And so I decided to go and to do a qualitative study to find out what are these people's perceptions, what are their experiences, why are they not using these devices. And so we used interview methods. So we did in-depth interviews of 10 individuals. Please, next slide. Just go to the next slide. I think I'll speak on that. Next slide. So, interviews of 10 individuals. The study was conducted in Lagos State because, first of all, Lagos State is kind of like a microcosm of Nigeria. It's a melting pot. We have people of different socioeconomic backgrounds. We have persons of different cultural backgrounds. So that's why Lagos State was chosen. Two centers were used. One was a government hospital and the other was a private clinic. The reason why those two different centers were chosen is so that we have a range of socioeconomic status of people of different socioeconomic status to interview. Because most of the persons in the private center were middle class and high class persons, while those in the government centers were from the lower class socioeconomic class. And so I wanted to find out, does their perception, does their experiences, does it differ across socioeconomic class? Next slide. Previous. So the criteria, there were certain criteria, the previous slide please. There were certain criteria. The first table. First table. No, where are you going? First table, please. So there were certain criteria that were used to determine the previous one, please. There were certain criteria that were used to determine who will be part of this study and who will not be part of this study. And unfortunately, by this time, there is a table for criteria. Please, can you put that up? Yeah, going accord. I have the one before. Yes, thank you. So there were certain criteria that were used to determine who are the people that will be participants in this study. First of all, the person had to be above 18 years of age. It had to be a resident of Lagos, speak English or Pidgin, can read and write, and living with a low vision for at least a year. It's supposed to be for living with low vision for at least a year. Have used one of the visual aids for within the past 1 year and not been the researcher's patient. I'll come to this part of having used one or more low vision aids in a year. Unfortunately, the second to the last criteria, all the participants in the government hospital, none of them met that criteria. Meaning that all the people that went to the government hospital and got a low vision device, none of them used that device for up to a year straight. And so we couldn't include them in the study because basically what we're trying to find out is that why are you not complying with the use of your device? But these ones did not even use it at all. They didn't even bother. Some of them didn't even collect the device. In fact, most of them did not even collect the device. And the few that collected the device didn't even use it for up to a year. So there was no way we could really gauge. So we had to remove that part of the study. We couldn't use any of the participants from the government hospital, which was quite unfortunate. Next slide, please. So the next slide is just a view of all the participants that were part of the study and the devices that they had used the device for. Next slide. So they were interviewed. The interview were recorded and transcribed. And after transcribing, the data was analyzed. In qualitative studies, what you do, we used what we call a thematic method of analyzing the data. So what we do is that we go through the data and pick out what we call themes and make codes of them so that we find out what is the general thing that the person is saying. And all these things the person is saying, what is the key points? What are they saying regarding these questions that have been asked? And the key areas addressed in the interviews were the individual's experience with the use of low vision devices, their family and societal perceptions, reasons for poor consistency of the use or non-usage of the low vision devices, and their reasons for compliance. Next slide. Next slide. Next slide. Okay, so summary of the findings. The findings were quite extensive, but summary is that, first of all, some participants experienced very little encouragement from their eye care practitioners. This was quite surprising, but also not surprising, because a lot of the people that were interviewed were like, I went to see my doctor. They did not say anything about low vision. I don't even know anything about low vision. It was until somebody else now told me. And my doctor just said, sorry, there's nothing I can do about your vision. And this. And so I've been living like that for many years until somebody now told me that if you go here, they can check and help you see it. So a lot of them have gone years without even knowing anything called low vision. Or even their doctor even telling them anything about low vision. And so that tells a lot about us as practitioners. Are we telling our patients that those ones that we can't help, with conventional devices? Are we telling them about low vision? Are we telling them that, okay, I can't help you here, but there's somebody that can help you? So that's something that needs to be worked on from our own angles. So while some others credit them with helping them with the use of the devices, a lot of them found the low vision aids very helpful despite the high cost, the inconvenience it posed, and its unattractive appearance. A lot of persons that I talked to before I started doing this study, they were just, a lot of practitioners were like, it's because the thing is they don't like using it, it's not fine, it's not, that's why they don't use it. I said, you are assuming. You're assuming that that is the reason why they are not using. Have you really asked these persons that use the devices why they are not using it? And so that was one of the reasons why I conducted this study. Next slide. Most participants, especially those using the more obvious devices, found it difficult to use in the public because of the reactions and comments it drew, and the younger ones were stigmatized by their peers. There was something that happened in this first part. I found out that a lot of them, they were very comfortable using these devices among, people that they were familiar with. Maybe people in their office. There was a particular lady that always used her device in the office, a banker. So she used her magnifying glass in the bank. She didn't mind. But when it now got to places like, okay, in the market, she didn't want to even try it at all. So the more familiar the person was with the environments that they were, the more willing they were to use these devices. And also, we found out that a lot of them found out that people were not, what is this one you're carrying? Why are you carrying this thing? So the average Nigerian does not know what low vision device is. It's strange. The average, so it also brought a lot of difficulties for them, because by the time they start to use it, people are like, what are you doing? What are you using? And so that's made them draw back and discourage them from using these devices in the public. Next slide. Also, interactions with family members. So family members were generally supportive, though concerned and curious about these devices and the issues with their eyes. Most of the people, they were comfortable using their devices with their family members. But funny enough, Nigerians, we have this culture. We are very secretive. We don't want our family members to know what is going on with us. So a person that has low vision is with his family members. He doesn't want to bring out that device, and usually they will not start asking him questions. I've seen cases where a patient has glaucoma, and he doesn't even tell his brother that he has glaucoma. Meanwhile, the brother, knowing that he has glaucoma, could even save his own vision. And so that's something that we need to break, and something even we as practitioners can begin to work on. Let's break out from that attitude of secrecy. We don't want people to know that you are dealing with this vision problem. A lot of the patients are not dealing. I said, why are you not using it at home? I said, I don't want my brother to know. I don't want my sister to know that I have issues with my eyes. So that is something we as practitioners also need to work on. Then also, factors that influence the use of the visual aids, device functionality, even less than the way the device looks like. Patients were more concerned about the functionality of the device. If I use this, will I be able to read? If I use this, can I sign my checks? They were even more concerned about, especially those of the elderly age. The younger ones were a bit more concerned about the aesthetics of the device. But the elderly ones were more concerned, if I use this thing, can I sign my checks? So let us not be hampered by the fact that the patient will not use it, does not like it. They will not use it, don't even bother telling them about low vision. Please, you'll be surprised that that patient will be so interested in using it, because all they care about is, will it give me good vision? Can I read with it? Can I sign my checks with it? Also, they had a lot of positive experiences and support from eye care professionals, and that was very important as a driver for compliance. Next slide. So we also talked about, I had to ask them, I was like, okay, so what are the things that will make you want to use this device? A lot of them were like, first of all, especially among the younger persons, they were concerned that this device should be modified to be more aesthetically pleasing, as in look more normal. I think that was what one of them, let it look more normal. and also the cost of the device, the ease of use. Ease of use was very common among the elderly persons because a lot of them have tremors as they get older. So holding a magnifier is quite an issue for them. It's not easy for them to hold it and say, okay, they want to read this, maybe a Bible for a long time. So even when we are as practitioners are prescribing these things, we have to take into consideration the person's age, the peculiarities with that individual. With this person, even though a magnifier will help this person, will the person be, with his age, will he be able to hold the magnifier for long? Even if a telescope will help this girl in her work, will she be able to use this telescope? Her work requires her moving around the shop. She's a shop attendant. Will she be able to use this telescope and walk around? If not, at the end of the day, they will get these devices and they will not use it. Also, it's very important that we motivate them on self-motivation, self-acceptance, involving their family members. I think that was another recommendation. Educating the public about what low vision devices were. There was a time in Nigeria that wearing glasses was strange. I think someone mentioned that wearing glasses was strange. But with time, as people got to know about it, they started using it. So, and that burden falls on us as practitioners. We need to start, in our own little way, start making the use of these devices normal, so that these persons can be integrated into the society. If not, a lot of them will not even be involved, and that is okay. Yes, thank you. And that is a burden. So next slide, I think I'm almost done. Also, implications, we found out that low vision devices are unfamiliar to the average Nigerian, to the average person. Participants using more obvious devices had difficulty using it. Family members were supportive, but cost of device functionality, convenience of use were factors that influenced the use of the low vision aids even more than the way the device looked like. Next slide. Next slide, please. All right. Can you switch? Okay. So, but basically, what the study found out was that we as practitioners have a lot to do. First of all, in making these devices commonplace. Second of all, we need to involve family members in the management of these persons. We can't just attend to the patient on its own, because that patient is not going to exist in a bubble. He's going to exist with the family members around them. He's going to exist in a workplace if the person is working. He's going to exist in a church environment or a mosque environment if they are involved in all those things. So we need to start to think beyond just attending to the individual. You attend to the individual, you give them these devices, they will walk out of your place and they will not use it because the society is not accepting of that. The society is not familiar with that. And so we need to start to make these devices commonplace in our society. Thank you. So any questions regarding this, I think?
Please, another round of applause for the presenter. Wait. Yes, we have a question.
Thank you once more. My name is Enechi Gebhardt. I'm happy with your presentation. At least, I will advise you publish the work, but with some adjustment.
Okay.
When you want it to be accepted as a publication, I think the sample size of 10 is too small. Okay, so you should see how you get your sample size proper. You look at the prevalence rate of such a work closest to you so that I can use it to calculate a sample size. It is when you get your sample size, maybe 30, 40, 50, or whatever, that you start working towards it until you get at least closer to that. That will also determine the timing for that your work. But what you have said is very okay, because we in low vision, we also notice that after prescribing many of these devices, some patients, many of them will not even use it, and they may end up just discarding it. So please, I think you need a very big applause. So you're welcome to the research world.
Thank
you have
you,
to
sir.
do it properly. Thank you.
Sir, I will. Thank you. I appreciate it. Sorry, there was something it was supposed to be on the slide, but it wasn't mentioned. It's important that we start to work with government agencies and NGOs to reduce the cost of these devices, because some of them are quite pricey. Even though it's not in this study, it was found not to be a significant driver, but it is also a driver for the use of these devices. Thank you.
Thank you, Dr. Adomi. Please, you can clap for her again. A question?
I'd like to thank the presenter once again for the presentation. Qualitative research is one aspect that is not explored so much in optometry and in Nigeria, not just, we all do a lot of quantitative research. And in qualitative research, the number of interviews you do depends on when you get to your saturation point. There is no, we say, sample size for qualitative research. It's not a quantitative research that she did. And sometimes you may need only 5 interviews, and you get to saturation point. That becomes the number of persons you interview. So the fact that she used 10 is still, in fact, some use only 5, 6 interviews, and you get to saturation point for qualitative research. I just wanted to clear that out. And then also to point out that from what she has presented, there is need for the association to go into partnership with producers of low vision devices. Because even to get the device is frustrating. We're trained in South Africa, myself, Babi, and Anne, then. So, and then Brian Holding used to help with the devices. Now it's no longer coming, you can't get it. Then somewhere in Kaduna, no, where is that? So it's such a big challenge getting the devices. So people call me sometimes, do you have this device? I don't have it. So even when they are willing to wear it, you can't get an affordable one to even give them. So if the association, that should be one of the things that should come out at this conference, to look for a way of collaborating with manufacturers of these devices to see how we can make it even available for patients to use. Thank you.
A round of applause for that contribution. We have to take one product presentation, because like it said, we have to go for commercials. But we're going to make it very brief. So I want to invite Miss Elizabeth Odewale of Nature's Field to give us a very brief product presentation. Please, a round of applause for her as she comes up.
All protocols are observed. Good day, distinguished professionals. My name is Elizabeth from Silken Limited, marketers of Nature's Field pharmaceutical products. So I'm just here to present to you basically on a unique approach towards the management of patients with age-related macular degeneration, that's AMD. Next slide, please. Okay, next slide. Okay, here is just talking about how important our eyes are to us, of course, which is a very important organ, and what price every individual would like to pay when it comes to getting their sight. Next slide, please. Okay, here I have some disease facts, which states that about 85% of all visual impairments and 75% of blindness could be prevented and cured worldwide. And of course, approximately, it's just disease facts we got from National Eye Institute to connote the importance of paying attention to helping in the management of patients with AMD or cataracts, glaucoma, visual impairments, and other eye diseases. And it says approximately 90% of the world blind people live in developing countries. Of course, Nigeria is still a developing country. We are not there yet, but we'll be there very soon. Next slide, please. Okay, here I have common eye disorders, the refractive error, AMD, glaucoma, cataract, diabetic retinopathy, and computer vision syndrome. But for the sake of time, which I want to strictly adhere to, I'll be talking about AMD, which, of course, you professionals understand that it is a gradual, painless, and progressive deterioration of the macula, which is, of course, located at the retina. Next slide, please. Okay, like I mentioned, AMD is gradual, it's painless, and a progressive deterioration. And a huge risk factor is aging. Of course, from the name, age-related. It develops gradually and moving from early to advanced stages. Of course, there are two types of the AMD, which is the dry AMD and the wet AMD. The dry AMD, of course, is where you have the yellow patches, the drusen's, scattered all around the macular region. And the wet AMD is, of course, when blood vessels are now formed around, tiny blood vessels formed around them, the retina. Next slide, please. Okay, for the prevalence of AMD, AMD accounts for at least 8.7% of all blindness worldwide, according to the study. And it's a common cause of blindness in developed countries, particularly in people older than 50 years. So we can see this type of disorder in patients above 50 years. And of course, it accounts for 8.7%. AMD is the third largest world cause, which is why, of course, my country took the challenge upon themselves, as of course we took it upon ourselves, to see how we can help contribute in the management, how we can make work easier for you professionals in the management of your patients with AMD. Next slide, please. Okay, here I have a picture of just a pictorial representation of a healthy eye and eye with AMD. I already mentioned that at the macular region, you have your yellow patches, that's the drusen's. Next slide, please. Okay, so this is a patient presenting AMD and, of course, a patient with normal vision. So here you would see that the vision is blurry, that's the central vision, whereas the peripheral vision is not yet affected. Next slide, please. Okay, next slide. So what are the impacts, what are the implications of AMD? Of course, anxiety would start, decreased quality of life, the patients begin to depend on the family or friends and the likes, then treatment costs, and of course, increased morbidity and ultimately increased mortality. Next slide, please. Okay, here I just listed briefly the risk factors of AMD, which I mentioned earlier is age, of course, smoking, genetics, diet, cardiovascular disease risks as well, and of course, alcohol. Next slide, please. So what are the symptoms? Of course, there'll be blurry vision, like I mentioned, from also the picture shown earlier. Then extra sensitivity to glare. You see the patients trying to stay on an image for a longer period just to capture the image, to be able to interpret and to be able to act on it. Next slide, please. Okay, next slide. So how do we manage? How do I come in? Of course, we have available management options. The first one is the use of eye antioxidants, which is where I come in. And other managements include lifestyle modification, the use of anti-VEGF, that's vascular endothelial growth factor, laser surgery, that's ultimately, and then avoiding UV or blue light. Next slide, please. Okay. Okay, this is just briefly talking about computer vision syndrome, because my product is also positioned to help manage that. And of course, computer vision syndrome, which is also called visual fatigue or digital eye strain, is actually a group of eye-related issues that result from prolonged computer use, tablet use, e-reader use, of which I believe we youngsters are very guilty of right now. And symptoms are basically caused by prolonged screen time. We move from our phones to our laptops to television and the likes. Next slide, please. Okay. Okay, these are the symptoms which are caused by the symptoms of computer vision syndrome, which are caused by poor lighting, glare on digital screen, poor sitting position, uncorrected vision problems, and the likes. Next slide, please. Who is at risk? Of course, for computer vision syndrome, I already mentioned the people at risk. Screen time, when you have longer screen time than normal, the patient is at high risk of having computer vision syndrome. Next slide, please. Okay, I'm looking at the treatment goals. What are the treatment goals? Of course, the aim and objective is to delay disease progression, improve the patient's quality of life, which is utmost for you professionals, and also for patients to come to terms with the new reality, especially patients with AMD, because they don't want to be dependent, they still don't want to come to terms to reality. And of course, utmostly to prevent blindness. These are the treatment goals for using eye antioxidants. Next slide, please. Okay. For treatment options, we have the non-pharmacologic and pharmacologic, which the pharmacologic is avoid smoking, exercise regularly, and the likes. And of course, the pharmacologic is the use of antioxidants, which you have your 3 C's, convenience, compliance of the patients. Next slide, please. Okay. Here is just briefly, one thing I've noticed about you professionals is you're very particular when it comes to ARET study. So we have to respect that. And of course, my brand was formulated, Nature's Field brand was formulated to ensure that it is ARET 2 compliant. ARET 2 compliant. And so, the objective of ARET, when it was carried out, was to evaluate the effect of high doses of eye antioxidants to see if they can delay disease progression, delay the AMD disease progression, and also prevent vision loss. Next slide, please. Okay, here I just have the ARET study design. Next slide. Okay, next slide. Okay. So why am I bringing my eye antioxidant to you? Why do I think it's very important? It is, eye antioxidants are very important because they are sufficient nutritional antioxidant that neutralizes the effects of free radicals. They are basically to mop off free radicals. Of course, talking about the yellow patches as well, which are the drusen's. And also, okay. Okay. All right. So I already mentioned the main objective of using eye antioxidant, which is ICAP. And this is my eye antioxidants, Nature's Field ICAP. We have it by 30, 60s, and we're at D14. Now, next slide, please. Just very fast. We have our unique constituents. I already mentioned that you professionals are always so particular about ARETs ARET study and to see if its eye antioxidants are ARET2 compliant. So yes, my eye cap, my Nature's Field eye cap is ARET2 compliant because it contains lutein, zeaxanthin, and of course, eye brighter powder, which are unique constituents that help clear the redness, and bilberry extract and the likes. So for more information, due to time, I would appreciate if we can visit our stand, which is D14 at the Executive Hall. So I can also talk to you more about the product, about the unique constituents of eye cap, all the way from Silken Limited. So thank you for your time, please.
A round of applause for her, please. Okay, please, I want to use this opportunity to appeal to the remaining product presenters to help us manage our time. Can you use 20% of your time to talk about the product and 80 to lecture us? So let's respect each other's time, please. On that note, please, one more product presentation because we have 2 scientific sessions to take. I want to call on... is it? What's her name? Okay, Dr. Nnadichie Dozie, please come and introduce yourself, and you have few minutes.
Good afternoon, distinguished colleagues, gentlemen and ladies. My name is Dr. Nnadichie Dozie, and I'm with Alternate Visions Limited. Sorry, slide. So, for want of time, I'll quickly introduce Alternate Visions Limited. We are an indigenous pharmaceutical company, and we've been in operation for about more than 2 decades now. And we've brought to your clinics a variety of genuine pharmaceutical eye preparations like Laxat, Laxat Plus, Brimopress, and all. And today I'm to present a unique product called Izine. Please, can I have the slides up? Thank you. So like I said, I'm to present a unique product to us today called Izine. Next slide. Please, let's be fast. Okay, it's actually indicated for minor ocular surface irritations. And our unique word for the product is that it's a unique brand that keeps it clear, keeps the conjunctiva clear. Next slide. So this is the presentation of how the product looks like. It comes in a 10 ml bottle. It has a light blue diamond-like container. It's actually a dimple bottle, unlike the cap and tip bottles you have for your normal eye preparations. So it lets out only 1 drop of the eye drop at a time. It's colorless and it's transparent. The color there is to prevent the product from being denatured by UV light. Next slide. So the composition, Izine contains tetrahydroxyline, and it also has excipients such as polyethylene glycol, sodium chloride, and it comes with a preservative, benzalkonium chloride. Next slide. Okay. Tetrahydrozoline is actually an alpha agonist. It's more specific for alpha 2 than alpha 1. That explains its activity as a decongestant. it does that by vasoconstriction of the conjunctival blood vessels, which helps to reduce edema as well. And this molecule can actually be combined with antazolene as well to manage your seasonal allergic conjunctivitis. Next slide. So, like I mentioned before, polyethylene glycol is one of the excipients of this drug. As an excipient, it also offers therapeutic.
Sorry for the interruption. We want to alert everyone. The last, Dr. Adomi, the presenter that talked about low vision, as she was up here making her presentation, someone had already taken her laptop from her bag. And it was observed that there was a young man that came around there. So I want to use the opportunity to alert the security and everyone else, please, be conscious of the movement around you. And please, can the security personnel help us to either seal off the place or be more vigilant, just to alert us that something just happened. It was exactly the reason why Dr. Obomo kept his bag here. In 2018, something similar happened. And it's unfortunate she didn't hand it over to someone. So please, let's all be on the alert, please. Thank you.
It's quite unfortunate. Kicking off from where we stopped, I mentioned that polyethylene glycol is one of the excipients and which offers some therapeutic value to the formulation in that it helps to stabilize the product and also adds its own value to the drug. It has a low molecular weight, it's clear, it's colorless, and is a viscous lipid. It's widely used in so many pharmaceutical formulations. Next slide. So polyethylene glycol, one of the advantages it offers, even as an excipient, is that it's a lubricant and it helps to protect the eyes from irritation and dryness. It also helps to spread the drug on the ocular surface when instilled, which helps diminish burning sensation. Next slide. So some of a little pharmacokinetics. The biological half-life of tetrahydrozoline is approximately 6 hours and is excreted chemically unchanged in the urine. Next slide. So what are the indications for Izin? Like I mentioned at the beginning of my presentation, is indicated in minor redness caused by minor ocular surface irritation. You can have redness caused by dust, by smoke, by even water. Sometimes when you see people who go swimming, or someone who just takes his bath and then their eyes are red, and then prolonged screen time as well. People who have that redness due to prolonged screen time as well can actually use this product, or after contact lens wear. Then ocular itching and burning of no known etiology. And then, like I said before, you can actually combine it with antazolene to treat seasonal allergic conjunctivitis. Next slide. So a little contraindication. Because Izin contains tetrahydrozoline, is contraindicated in individuals or patients who are hypersensitive to tetrahydrozoline. And also patients who are glaucoma patients as well, especially the closed angle glaucoma patients. Because it's a sympathomimetic amine, it causes transient mydriasis on instillation. It's actually transient, but you understand our goal in managing in the management of glaucoma is always to bring down the pressure as much as possible. By causing mydriasis, you might be doing the reverse to your patient. That's why it's contraindicated there. And then you also have some adverse drug reactions. You can have adverse drug reactions with our antidepressants, first generation antidepressants. That's the monoamine oxidase inhibitors. Next slide. So dosage, it's used 3 to 4 times daily. And then precautions why use can be, okay, preferably 3 to 5 days and at most 10 days, because you could actually have rebound hyperemia as well, with long-term use of tetrahydrozoline. It's not to be ingested by mouth. It should be kept safe and out of reach of children. And if symptoms persist after that length of time, you should see your eye specialist. Next slide. So what are our benefits for choosing to prescribe this very product, Izine? It has an attractive packaging. It encourages patient compliance. I've talked about the dimple bottle, how it only expels 1 drop when you apply pressure to the bottle. It has a prompt vasoconstrictive ability. In fact, in 60 seconds, you should be able to, get result. It has a dual mode of action in that it relieves redness and also lubricates the eyes. Next slide. So Izine keeps reddish eyes clear, lubricates the eyes, cools and refreshes the eyes. Next slide. So when you are faced with the dilemma of prescribing a product that you could use to treat minor ocular irritations, choose Izine. Thank you so much. Please, I would like to take questions. Any questions? For want of time, I wanted to continue with the second product, Catalyst. But I think I'll leave it at that. But Catalyst is a product which we formulated for our cataract patients to help to maintain the integrity of the capsule of the cataract. Thank you.
Any questions or your location?
Okay. We are at stand D17 at the Executive Hall. So if you have questions, inquiries about this product or how you can get them, please do reach out to us. Thank you so much.
A round of applause for him, please. While we get ready for the 3rd scientific session or oral presentation for the day, we want to hand over the mic to the last product presenter. And you know how long we have. Introduce yourself.
Good afternoon. All protocols duly observed. My name is Pharmacist Taiwo. I work with Vita Biotics, and I'm here to present our product, Visionis. So our presentation will be in 2 parts. Just a very brief clinical introduction and the product presentation, all within the time limits. So at Vita Biotics, our mission is to empower people to live healthy through innovation in nutritional healthcare. So I'll hand over to the doctor to quickly present.
Good afternoon, everyone. Dr. Ume. All protocols duly observed. Okay, so I would like to just refresh our memory on what we know about age-related macular degeneration and antioxidants. So here's an outline. Next slide. So I would like to briefly remind us of the anatomy of the macula. The macula is located in the posterior pole of the retina, and it measures about 5 to 6 millimeter in diameter and subserves the central 15 to 20 degree of vision, which represents fine details of vision. So anything that affects the macula will substantially reduce the reduced vision. So key anatomical features. So within the macula, we have the fovea, and within the fovea, we have the foveola which are very sensitive in the macula. And then we have the retinal pigment epithelium, which is just beneath the layer of the neurosensory retina. And then the Bruch membrane, which is between the retinal pigment epithelium and the choriocapillaries. Next slide, please. So this is just a picture representing what the normal fundus should look like. And that area, so the macula is located temporally from the optic disc as is shown there, and then the central or the inner dark center area that you can see there is the fovea, like I mentioned before. Next slide, please. Next slide. So age-related macular degeneration is actually a degenerative disease, as the name states, and is characterized by specific clinical findings, including drusen's and retinal pigment epithelial changes, and later stages of the diseases are associated with vision impairment. Next slide, please. So now, it has already been stated the epidemiology of ARMD, but in Nigeria here, a multi-center prospective study that was done showed the prevalence to be about 0.91% in patients who are aged 44 to 95 years. So it's commoner among patients who are actually 50 years and above, generally in population worldwide. So it's a very common disease. It's the commonest cause of visual loss or visual impairments in patients who are 50 years and above in the developed world. Next slide. So there are several theories about the pathogenesis of ARMD, but a common finding is usually the presence of drusen's, which are discrete materials or deposits found between the RPE and the Bruch membrane, and their precise role actually in AMD is unclear, but they are thought to be associated positively with AMD when there's an increase in number and an increase in the size of drusen's. It shows that there's a progression of the disease. Next slide, please. Next slide. Okay, so these are just pictures. Previous slide, please. The previous slide. So these are pictures showing drusen's, and then almost done. Okay, so these are pictures showing drusen's. You can see in the first picture there are some discrete yellow light deposits around the macula, and then look at the next picture showing progressively increase, the sizes progressively increase, and the numbers also of the drusen's increased. And the third one below, you would see some pigmentary changes also associated with the drusen's. This just shows progression of the disease. Next slide. Next slide. So conventionally, there are two types of ARMD. We have the dry and the wet. The dry is the more commoner form, which is present in about 90% of cases, while the wet is present in 10%. So the dry mainly is the presence of the drusen's and the progression in number and in the size, while the wet is present when there are new vessel formations, which are easily friable, leading to bleeding and other complications. So next slide. Next slide. So, okay, these are another form of classification, which is a clinical classification based on the drusen's and just the different sizes of the drusen's. Next slide. Okay, so the risk factors I've just quickly mentioned: age, like I mentioned, greater age. Those 50 years and above, race is commoner in Caucasians. Hereditary, as found in first-degree relatives, you have a 3 times fold risk. Then smoking 2 times fold. Hypertension, cardiovascular diseases. Dietary factors, obesity, and high fat intake has been found to be associated. And then it has been shown that in some people, a high antioxidant intake is actually protective. So other factors are aspirin, cataract surgery, blue iris, sunlight exposure, and the female gender. Next. So these are just the clinical features, that the progression is actually faster in wet ARMD and slower in dry ARMD. So the patients usually would have a more severe course with wet ARMD. Next slide. Next, please. All right, so these are some of the investigations that can be done. Next slide. And then the treatments, basically with antioxidants, and the other treatments are done for basically the wet ARMD. Antioxidants would mainly suffice for those who have the dry and wet ARMD. Next slide. So the importance of antioxidants in the treatment is actually it's done from a very large study, the RED study, age-related eye disease study, which found that taking high dose of antioxidants was actually protective and actually reduced the risk of progression to an advanced disease of ARMD. Next slide, next slide. So these the recommendations show that in individuals that would benefit most are those with extensive intermediate drusen, one or more large drusen, geographic atrophy in one or both eyes, and those with late ARMD in one eye. The next slide, please. Also showed that there was a reduction in the risk of ARMD at 10 years, in order of 25 to 30% in those who had more disease, more advanced disease. And how, so next slide, let's just move, next slide. Okay, so basically, all right, so let me just move. So he's going to talk about the importance of the antioxidants. I just did an introduction.
Thank you very much for your attention. And we are moving next to the Vital Biotics supplements Visionis. Next slide, the next product. So we are going to treatments now. Okay, so we've talked about the AMD, age-related macular degeneration, and Vital Biotics, the Visionis supplement, contains all the necessary antioxidants, lutein, zeaxanthin, the carotenoids, and all the other essential, bilberry, very essential for treatments, for management, and for prevention of progression of age-related macular degeneration. Next slide. So we have Visionis, which is a comprehensive research-based formula developed to provide nutritional care for eyes and vision. These are the presentation. Next slide. So Visionis, like I mentioned, contains lutein, contains citrus bioflavonoids, zinc, vitamin C, vitamin E. Next slide. So what are the qualities of a good nutritional antioxidant, vitamin C, vitamin E? According to the RED2 study, age-related eye diseases study, we have all this listed here. Next slide. So we have this study, ELIPSA study. Next slide. Which was done to check for the effectiveness of lutein and zeaxanthin in photopic and scotopic aging. And the results of that showed, next slide. The results of that showed that there was 68% increase in lutein group for macular pigment optical density versus the placebo group. That's the group that did not use the lutein antioxidant. Next slide. So the summary of this is that the AMD is a major clinical study. We've said that macular pigment can be enhanced in the eye with Visionis because it contains lutein. Next slide. So, okay, this is just about the macronutrients. Next slide. So I just need to quickly mention that lutein and zeaxanthin are just two of the 600 naturally occurring carotenoids, and they're actually responsible for sharp and detailed vision. Next slide. So in summary, one capsule of Visionis per day can help to impede the progression of degenerative macular changes, help retard age-related patterns of lens breakdown, prevent the risk of cataracts, maintain normal eye moisture, increase the macular pigment density, prevent accumulation of drusen, as well as is a nutrient therapy for healthy eyes, a general multivitamin, and is not necessary a multivitamin is not necessary for addition to Visionis, because Visionis is actually a eye and whole body formula. And we are available at booth 15, SB15 at the back. Visionis is marketed by Litmus Life Sciences. Thank you very much. We hope to see you at our booth.
Thank you for the presentation. I meant to understand that it is lunchtime. And we are supposed to take the next presentation, but I should announce that lunch is ready. And I have the directive of Mr. President to announce it this way, that delegates 30 years and above should go behind the stage for their lunch, while below 30 years should go upstairs. I had to clarify this directive very well to be sure that was how it was given. And I was assured that it was Mr. President himself that gave this categorization. So I'm only here to obey directives. I wouldn't know why that is, but they know better. 30 years and above, 30 years post-graduation goes behind, while below 30 years takes the exit door and goes upstairs. I think it's instructive and in the interest of our nutrition that we refresh before we take the last two presentations. Do you agree with me? Or do you think we should take the two presentations at once and go from there? Lunchtime, please. All right. Please, let's be snappy about it and reconvene for the last two oral presentations, which will mark the end of the scientific sessions before we go home, go back to your hotel to get ready, or come back here for the AGM. You have a question? Exactly what I was battling with. Let us finish. That directive I was given. Do I go ahead and call them? Do I go ahead and call them? Okay, it is by popular demand. Please, let's have the lunch quickly and finish up in no time. Thank you. No, shouldn't be. Shouldn't be. Please, fellows and delegates 30 years and above should go behind. For fellows and delegates 30 years and above. Please.
Please, while going for the lunch, let's move with our backpacks and every of our belongings. Thank you. Please move with your backpacks. Don't leave your backpacks on the chairs. Please move with your backpacks and all your belongings while going for the lunch. Do not leave your backpacks on the chairs.
Yeah.
Kindly move with your bags while you go for your lunch. Do not leave your bags or your belongings on the chairs.
Thank you.
Thank you. Announce to them that the AGM is going to start by 4. That was 4:45.
Good evening, delegates. I want to welcome you back from the lunch and to announce to you that we're commencing the remaining oral presentations right away, and we have limited time. In fact, the lectures or the presentations will have to be shortened because I have a standing order that the AGM must start by 15 minutes before 5. So it means that I'm calling on the next presenter, Dr. Obiwanne Jr., to give us his oral presentation. Please, a round of applause for him as he climbs up for his presentation.
All right, good evening, colleagues. I'm Dr. Obiwanne Chukwuemeka Jr. I will be talking today on myopia management. Basically, we've heard from Professor Veseri's presentation. We talked about trends in myopia control in Africa. We looked at the current practice patterns of practitioners around Africa regarding myopia management. But today we're going to be looking at taking that research down to the clinics and learning from it step by step. I head the cornea and anterior segment specialty of the lens ophthalmics. So I'll be speaking aside from the research perspective, also from clinical experience from patients that we have managed over the years. Next slide, please. So as optometrists, we know that, next slide, please. All right, as optometrists, we're already used to what myopia is. We know that myopia is a condition where you have parallel rays focused in front of the retina, even when accommodation is relaxed. But the International Myopia Institute, next slide. Okay, the International Myopia Institute defines myopia as a cycloplegic spherical equivalent refraction of less than minus 0.5. Now, there are different, the previous slide, please. There are different classifications for myopia around the world. There is a classification based on the degree, the age of onset, and what have you. But for clinics, we would define myopia as low when it's less than 3 diopters, between 3 diopters to 5.75 as moderate myopia. Greater than 6 diopters, we would say that's high myopia. Now, there is also a separate definition for pathological myopia. We would consider pathological myopia as myopia associated with other posterior segment degenerations, and when the axial length of the eye is greater than 26 millimeters. Previous slide, please. You're going too fast. The prevalence of myopia varies around the world. It depends on what study you're looking at, what was the definition or criteria used in defining myopia. The current standard, or what the International Myopia Institute recommends, is cycloplegic refraction for you to determine whether a patient has myopia or not and to grade the refractive error properly. The prevalence of myopia around the world varies, like I said. In China, it's as high as 65%. In Taiwan, about 85%. In Africa, the prevalence of myopia tends to be low. But it's also possible that it's been underestimated because there are not too many studies that have looked at prevalence of myopia. A recent meta-analysis done by Veseri and a couple of colleagues put the prevalence of myopia in school-age children at 4.7%. The studies that have looked at myopia in Nigeria itself have reported prevalence that varies from 2.5 to 6.5%. But keep in mind, most of these studies do not involve the use of cycloplegic refraction. Most of these studies are done in a small subset of population, so it's very possible myopia is being underestimated. And again, it doesn't take into account the difference in the prevalence in urban areas and rural areas. But certain things before we start talking about, previous slide please. Before we start talking about myopia control, why is it important? Why are we concerned about myopia control? We noticed that from a publication in 2016, Brian Holding and his colleagues had projected that if we continue at the way we are going, by the year 2050, half of the world's population will be myopic. And 10% of that population, that's about 500 million people, will have high myopia. And we know that high myopia has certain things associated with it, certain pathological changes associated with it. So why are we concerned? Because as optometrists, day in, day out, we see patients with myopia. We're involved in sometimes managing the complications that these patients have, and we're sometimes we find ourselves having to refer these patients for certain surgical procedures when the complications set in. But does it not bother you when a myopia patient walks into your practice and you realize that the myopia is increasing, but then you still go ahead and do the same thing? The myopia increases, you give another pair of single vision lenses. The paper Dr. Veseri had presented actually showed that most practitioners in Africa believe that single vision lenses controls myopia, which is not true. But when you see a patient with glaucoma, for example, you don't wait for the visual fields to deteriorate before you start managing. You don't wait for the retinal nerve fiber layer to start thinning before you start managing. You don't wait for the patient to lose sight before you start managing. Why do we do the same thing for a condition that there has been evidence over the years that it can be controlled, but as clinicians, maybe because we don't read papers, maybe because we are not involved in clinical research, maybe we are not updating our skills and ourselves, we do the same thing over and over again, expecting a different result. Next slide, please. So the essence of today's presentation is to introduce us to the ideas of myopia management. Next slide, please. And how to go about it. We'll talk about some myths about myopia. I'll just run through this quickly. Dr. Veseri did mention this, that sometimes the reason why some people delay in obtaining spectacles or obtaining correction is because we feel if the child doesn't start using glasses too early, maybe the myopia would not increase, or it won't get worse, or they won't get used to it. That's not true. Studies have shown that whether you do not correct the child, whether you overcorrect the child or you undercorrect the child, they are all myopogenic. So overcorrection, undercorrection, or no correction does no good for the child. Sometimes you hear people say wearing glasses makes the eyeball look smaller. Well, that's because it's a minus lens and you're looking through it, so it magnifies the eyes. But that's besides the point. Okay, I talked about undercorrection. The part I want to really emphasize here is single vision glasses or spectacles or contact lenses. It does nothing for myopia control. Myopia correction is different from myopia control or myopia management. When you're correcting myopia, you're trying to improve vision. When you're controlling myopia, you're trying to prevent it from getting worse, trying to prevent the axial length from increasing, trying to prevent pathological changes associated with myopia. Previous slide, please. Now, there are certain risk factors associated with myopia with developing myopia or the myopia itself. Previous slide. The first risk factor is age. The younger the child, the higher the risk factor of developing high myopia. The younger the age of onset of myopia, the higher the risk factor of developing myopia. Now, sometimes you see children in your clinic and you do a cycloplegic refraction and you notice that the child has low hyperopia or emmetropia, and you think that that's a good thing. It's actually not a good thing. The International Myopia Institute has shown or defined something called pre-myopia as a state where you have less than 0.75 diopters of cycloplegic refractive error. Now, the thing is, by the age of 7, you're not expecting a child to have a cycloplegic refraction of 0.75. It should actually be showing more hyperopia. Now, what happens is, as the child gets older, the axial length will increase. As the axial length increases, they will go from low hyperopia to emmetropia, and then become myopic. And there are certain pathological changes associated with that. Previous slide. Aside from young age, other risk factors associated with myopia is increased screen time, increased use of digital devices, less time outdoors. Please go back to the previous slide. Previous slide. Thank you. Other risk factors associated with high myopia is parental history of myopia. I already talked about screen time and digital device use. Ethnicity, again, mostly Asians have high myopia compared to other ethnicities. We noticed from research and meta-analysis data that parents who are myopic tend to have children who are myopic. And when a parent has myopia, research shows that the child often ends up almost twice the amount that the parents have had. Next slide, please. Now, looking at the different degrees of myopia we talked about, you would almost think that, okay, we would wait until the myopia gets significant before you start intervening or doing myopia control. Like I said, I do practice myopia control, and I often have patients referred to me for myopia control, but most times those patients are referred late. Practitioners will often wait until it gets to -8, -9, -10. Believe it, I've seen as high as -32. But that's not the time to do myopia control because you have already missed the mark. You've already missed the point where you could have prevented it from turning into pathological myopia. The complications associated with high myopia is myopic retinopathy. The patients often have cataracts, sometimes posterior staphyloma, glaucoma, and what have you. Oftentimes, they end up becoming low vision patients. Sometimes it leads to psychological issues like depression, anxiety, and there's the financial burden associated with it. Next slide. So if you realize that these complications can occur, and if you know that there are certain things that you could have done as a practitioner to prevent it, would you wait for the child's myopia to progress before you start intervening? Next slide, please. Keep going. Next. Next slide. All right, so remember I told you if you wait until it gets really high, you've already missed the mark. I have seen patients who have myopia as low as -2, and I'm having to refer them for retinal barrage laser due to the lattice degenerations they have on the retina. I have seen patients as low as -3 having retinal issues or other posterior segment issues due to the type of myopia they have. So as you can see from the slide, there is no grade of myopia that's actually. Okay. Next slide, please. All right, so before we start talking about myopia control, you need to understand how myopia even progresses. There is a neurological part which we fully don't understand, truly. There are certain studies that have looked at things like the enzymes on the retina that controls the strength of the sclera, things like the antioxidant levels, dopamine levels and all that, but there is no true understanding of the neural mechanism of myopia. But what we do understand is the optical mechanism by which myopia progresses. Now, there's a professor called Professor L. Smith. He's one of the people who actually put this theory forward. Next slide. So there is something called peripheral hyperopic defocus. Now, what traditionally we believe or we tend to think over time is that the retina is just a flat surface, but it's actually curved. Now, when we refract a patient and you give your single vision lenses or single vision spectacles or contact lenses, what you're actually doing is correcting the refractive error at the central part of the retina. But at the periphery, you have moved the plane backwards and you induce something we call relative peripheral hyperopic defocus. So what Professor L. Smith and his colleagues did was they played around with that peripheral hyperopic defocus and noticed that if they correct peripheral hyperopic defocus, the axial length did not increase. So that became the optical mechanism by which we strive to correct myopia or prevent myopia progression. Next slide. So the ideal treatment for myopia would not be just correcting the central retina. The ideal treatment will be taking care of peripheral hyperopic defocus, actually by inducing myopia in the periphery. Because when you have the target behind the retina in the periphery, there is an optical stimulus that causes the peripheral retina to move backwards to correct that peripheral hyperopic defocus. And in order to correct that peripheral hyperopic defocus, the entire axial length increases. Next slide. So all the forms of myopia control available now, except the pharmacological ones, use that theory. Now, for instituting myopia control in clinical practice, we already have the tools. There are things that we already use. There are things we already know. It's something that can be done. It's just for us to take the bold step and decide to do it the right way. First of all, refraction, which we already know how to do, but emphasis on cycloplegic refraction. We usually will do keratometry and corneal topography to rule out that the patient does not have keratoconus, so that's why the myopia is not progressing. If you're going to be using orthokeratology as a form of myopia control, you would want to have a corneal topographer because it's important for you to do that. Slit lamp examination, you can't overemphasize that. A dilated fundus exam, because remember, a lot of the complications you're trying to prevent or cause in the posterior segment, so you have to be able to view the posterior segment and the peripheral retina to be sure that those complications don't set in. Axial length is also important. Now, before now, you would only find biometers in the clinics of ophthalmologists because you're trying to calculate IOL powers for refractive surgery, for cataract surgery, or maybe some forms of refractive surgery. But currently, for myopia management, the standard recommends that you also measure the axial length, because aside from the cycloplegic refraction changing in these patients, the axial length increases. So it would be foolish of you to just check the power without looking at the axial length, and we'll talk about why axial length is important. There are other things that you should look at when you're doing myopia control: binocular vision. If you have an OCT, great, because it helps you look at structural changes that occur in these patients. Next slide, please. Next slide. So, okay, yeah. So why is axial length important? Like I said, aside from monitoring the axial length of these patients and the cycloplegic refraction, you also need to realize that axial length itself can be an indicator that you can use in judging the health of the eyes in a myope. We know that for every little change in axial length, as small as 0.3 millimeters, it corresponds to 1 diopter of refractive error. So you may have a child who comes into the clinic, has an axial length of maybe 25 millimeters, and you see the child in 6 months or maybe a year's time, and the axial length has become 25.3 millimeters. That child has progressed 1 diopter just from 0.3 mm change. If you see someone who's changed by as much as 1 millimeter, it corresponds to 3 diopters worth of change in the refractive error. But aside from that, the axial length serves as an indicator for certain risk factors. We know that an axial length greater than 26 millimeters, 25.9 actually from the studies, shows that, puts the child at risk of developing myopic maculopathy. Now, there are different grades of myopic maculopathy, but the most common one I'm sure a lot of us have seen is you look at the back of a myope's eye and you notice the fundus looks tessellated or tigroid in a way. That's actually grade 1 myopic maculopathy. Now, it goes a step further and you start having macular scars, chororetinal scars, posterior staphyloma, and what have you. And sometimes what's actually sad is if you look at the files of patients who have high myopia in your practice, you can actually tell that at some point that -11 sitting in front of you was just a -1. And it's something that you could have prevented from getting to that point. Next slide, please. Now, aside from looking at the axial length, there are certain other structural changes that you would look at. But it does not mean that if you do not have an OCT or if you do not have a corneal topographer, you cannot start up. With instruments as basic as the bifocals that we already know, with instruments as basic as some of the contact lens options which I'll be discussing, you can actually institute myopia control. But I would like to repeat again that single vision lenses, whether spectacles or contact lenses, does not do myopia control. It only corrects vision, gets your patient to 20/20, but that's not myopia control, that's myopia correction. Now, for myopia control, we all know that we all prescribe bifocals. For presbyopes, we prescribe progressive lenses for presbyopes. But did you know that that can give almost 30% myopia control? The idea is the add portion of the bifocal or your progressive lens gives or corrects the peripheral hyperopic defocus in the peripheral retina and has been shown to slow myopia progression by as high as 30%. So if you do not take anything away from today, when you see that progressive myopia in your clinic, at least prescribe a progressive lens or a bifocal lens for them. There are other newer designs of lenses we call myopic defocus lenses. Essilor has the Stellest lens, Hoya has MyoSmart lens. What these lenses do, next slide, is in the central part, the central 9 millimeters of the lens, it's where you have the main correction for distance vision. But around it, you have something we call a spherical lenslets. Now, this is a design of a lens we call defocus incorporated multiple segments. This technology was actually studied in the Hong Kong Polytechnic University, bought off by Hoya, and they developed the MyoSmart lens. So what it does is, each of those small circles you see there has a diameter of approximately 1 millimeter and an add of about 3.5 diopters. Again, it takes us back to the fact that they are trying to correct peripheral hyperopic defocus. So in myopia control, we believe this. Any ad anywhere will do some good. Whether you're giving it in form of bifocal, whether you're giving it in form of progressives, whether you're doing it in form of myopic defocus lenses, you're going to be doing your patient a lot of good just by prescribing one of these devices. Sadly, we don't have any of these myopic defocus lenses yet being marketed in Nigeria, but we all know bifocals. We all know progressive lenses. We all prescribe them day in, day out, and it's something that you can use for your patient. Next slide, please. Now, keep in mind, next slide, keep in mind that these options, spectacle options, next slide, please, for myopia control, only gives about 30% myopia control. Although the lenses from MyoSmart and Essilor, that's the Stellest lens, promises up to about 67 to about almost 70% myopia control. Now, the next question you would ask me is, how do you determine the ad for these patients? Again, because of time, I'm just going to rush through this. Maybe some of this will come up in the questions. But generally, what you want to do is you do a dynamic retinoscopy for the patient. I'm sure if you know how to do some binocular vision tests, you remember the one that's for dynamic retinoscopy or your MEM retinoscopy. Now, what you do is when you get that MEM value or the lag of accommodation, remove 0.5 diopters from that, and that usually is the ad that you would give. In case you do not know how to do a MEM, you can just Google it or go back and read about it. It won't take you 5 or maximum 2-3 minutes. You do it, and it's simple. But what you need to understand is most of these studies that have looked at spectacle options for myopia control have studied ads between ad 1 to ad 2. So most times we end up giving an ad of 1.5 to these patients. But you need to keep in mind the binocular vision, because if you're giving an ad, you need to understand that if the person has a near exophoria, it's going to cause the eyes to diverge more. So a clinical trial was done to look at patients who they had given ads in terms of bifocals for myopia control. And now they split the participants into two. One group got ads regardless of their near phoria or distance phoria or what have you. Another group got ads with basing prisms incorporated into it to counter the exodeviation that the ad gives. Now, what that study found was that patients who had progressive myopia and near isophoria were served very well with progressive lenses or bifocals. But patients who had near exophoria, which you would expect to diverge more, did not fare very well in terms of myopia control with bifocals, except when the prisms were incorporated into it. So what you can take away from this study is that if you have a patient who has progressive myopia with near isophoria, you're good to go with your both bifocals or progressives. But if the patient has near exophoria, which is not compensated for when you check the reserves, it'd be better to incorporate prisms into it. What the study actually did was incorporate 3 prism diopters basing into the ad to be able to counter that effect. And going forward, that study was incorporated by another company, and they came up with a lens called Myopilux. Next slide, please. There are other options. There are contact lens options, multifocal contact lens options, autokeratology. Sometimes you combine with atropine. I'm going to breeze through this part because of time, but it's important that you realize that these options give better efficacy compared to the spectacle options. Next slide, please. For the contact lens options, multifocal lens options, you want to wait until the child is at least 6 years and above. Research has shown that contact lenses are actually safe in this age group. There have been randomized controlled trials, meta-analysis, systematic reviews done on these subjects, and it's shown that contact lenses are safe in children, especially before the age of 13. The reason is because it's mostly the parents who are taking care of it. It's mostly the parents who you teach the insertion and removal. It's the parents who realize the essence of what you're doing and they stick to the instructions that you give them. I have prescribed contact lenses to God knows how many children, and they are very, very good and compliant patients. It's the adults who ask you a lot of questions and give you more headaches. The children are usually more friendly once they understand what you're trying to do. For multifocal lenses, we tend to use greater ad compared to when you're doing spectacle lenses. Because there was a study called the bifocal lenses in nearsighted kids, there was the Blink-1 and the Blink-2 study. So the Blink-1 proved that you could use multifocal lenses to successfully control myopia by as high as 70%. Compared to the 30% you get with spectacles. But the Blink-2 study showed that you could use and add as high as 2.5 diopters to get the best form of myopia control. There are other options like orthokeratology. You have to have a corneal topographer to be able to do this. It's something that you need to realize you would require more training to do. I've done it for a couple of patients, and it gives the best form of myopia control with the added advantage of no use of spectacles or contact lenses throughout the day. So the children have clear vision throughout the day without having to wear the spectacles or contact lenses. They only put in orthokeratology lenses at night before bedtime, and it gives greater than 70% myopia control. Next slide, please. Next. So these are just designs of how to design an orthokeratology lens. I've talked about contact lens safety, so next slide, please. So we go to the pharmaceutical options. Now, this is another area that can actually be very well explored in Africa. Now, we all know what atropine does. We all know that atropine dilates the eyes, leads to cycloplegia. But did you know that there have been studies as far back as the 70s that have shown that you can actually use atropine to control myopia? But the side effect is obviously atropine will cause the pupils to be dilated and lead to cycloplegia and blurred near vision. Now, there are several studies that have looked at using lower concentration of atropine to achieve the same effect. There was the ATOM study, again, there's a clinical trial. There was a LAMP study, another clinical trial that showed that you could use concentrations of 0.01, 0.025, and 0.05% atropine to get good myopia control without the side effects of the cycloplegia that you would normally get and the midriasis that you would normally get. But however, in most of these studies, about 25% of the patients still experienced a bit of glare from pupils being dilated about 1 to 2 mm and a bit of loss of accommodation by about 1 to 2 diopters. So if you're going to prescribe low-dose atropine to any patient, you would need to counter that with a bifocal lens to reduce the near vision issue. Next slide, please. I think we can just go to the end. I think I've talked about most of them. So keep in mind, myopia control, as I said, is something that you can actually incorporate into your practice. You already have the tools. There are things that you're already used to doing. But when do you think you can stop myopia control? Most times we recommend by the age of between 20 and 21, because we know that by then, most of the patients would have stopped progressing. Because if you wait I've seen some people think that some children will stop by 18, but as you can see from the COMET study, by 18, about 23% of people were still progressing. So the idea at the end of the day is continue myopia control until the child gets to the point where they are no longer at risk of progressing before you take away the intervention. Some of the interventions you have to taper down, but we'll save that discussion for another time. Thank you so much.
I want to commend Dr. Obiwanne for a well, arranged slide and presentation. Thank you so much. I'm sure we have questions for Dr. Obiwanne. We're going to take questions now so that he can respond. Do you have questions regarding myopia control, regarding the method you've been using? I'm sure when the questionnaire on this study, went out some months ago, many of us may have, filled the spectacle correction as their own means of controlling myopia, but we have learned today that it's correction and not control. So do we have any questions for him? It's a very relevant topic, and I commend him. Okay, there are no questions. That means it was well understood. Thank you. Another round of applause for him, please. Okay, we're going to take the last scientific session, oral presentation, on a topic that borders on the theme of this conference, which is collaboration. There's a study that involved different groups of health professionals, and we have one of us here to make the presentation, Dr. Moneke Hippolytus. Please help me welcome him with a round of applause. Dr. Moneke Hippolytus. What is the topic? It's a long one, so.
Good evening, colleagues. You are welcome. So my name is Dr. Moneke Hippolytus. to present a topic titled Antibiotic Susceptibilities of Eye Swabs from Eyes of New Babies or Newborn Babies born through spontaneous vaginal delivery and cesarean section. Okay, while we wait for the technical committee to come up with the slides, we know that a healthy newborn baby eyes has no ocular microorganism at birth. But just few minutes after birth, the baby's eyes begins to acquire microorganisms at the surface of the ocular surface. So the question is, how? Next slide, please. So how do a healthy neonatal eye acquire microorganisms just after birth? So studies from researchers Roy and James discovered that babies that are born, particularly through the vaginal means, acquires microorganism through the genitourinary tract of the mother as one of the means through which happens by the passage of the baby when the baby is coming out from the birth canal. And another means through which that happens is when there is what we call prom, which means premature rupture of amniotic membrane. That is when the amniotic fluid leaks before labor begins. And we know that the amniotic fluid functions to provide buffer for the neonate while in the uterus, and also to protect the baby from having any form of infection entering into the uterus. So if this happens, that the amniotic fluid leaks before labor, then the baby is exposed to danger of acquiring infection. Next. Another means through this happens is through prolonged labor, which is defined as labor which takes place more than 12 hours, or labor which requires augmentation of oxytocin in order to be made to proceed, according to Jost van Roosmalen in 1991. And another means through this happens is, of course, before a prolonged labor takes place, or rather leads to constant digital examination of the cervix. And that constant digital examination of the cervix leads to possible introduction of microorganisms into the uterus, thereby endangering, or rather making the baby more liable, more disposed to having microbial infection when coming out. Another one means by which this happens is through prom that occurs together with the prolonged labor. That is when there is premature rupture of amniotic membrane occurring together with a prolonged labor, then the baby is a very risk of acquiring microorganisms on the ocular surface while coming out. Another means is through the presence of bacteria in the surrounding air of the labor ward, and also perhaps in the maternity theater, and also by the level of care provided by the hospital personnel who are handling the babies, the birth of the baby. Next slide. Next slide, please. So, most of these infections to a newborn baby, it always takes place within 24 hours after birth. And that's when these things more happen. But in some cases, it may even take less than 24 hours, depending on the amount of care provided by the nurses and the matrons who take care of this delivery. Now, we know there are two modes of delivery. We have this delivery through the cesarean section, and this is a kind of delivery by which surgeons make a cut through the mother's abdomen and through the uterus, and is the world's most oldest form of surgery. Now, there are indications for surgery. One of them is the history of a previous CS birth. Next slide. the cephalopelvic disproportion, when the fetal head and the pelvis are not of the same size. The fetal head is bigger than the pelvis, where the baby is presenting breech, preeclampsia or eclampsia, multiple pregnancy, and so on and so forth. So all this could be indication for why a woman might have to undergo cesarean section delivery. Next slide, please. Then another another mode of delivery is the normal means of delivery, which we know, spontaneous vaginal delivery, in which the form of the baby, in which the baby comes out of its own through the vagina without the use of tools like forceps or vacuum. So this is a normal way we all know that a major way through which a baby can be delivered. Next slide, please. Now, what are the study objectives? Then our study objective is to investigate the antibiotic susceptibilities of isolates from the conjunctiva of newborn babies delivered through SVD and CS. We want to know what are the bacterial organisms we can get from this form of deliveries. What exactly, how sensitive are they to antibiotics? We are going to test them in order to know whether there's going to be any better means or any way that we can, any better antibiotic that you can use to treat them in case neonatal conjunctivitis arises. And also want to determine if there is a relationship between mode of delivery and the bacterial growth yield. Next slide, please. So these are the materials we used. Some of them are listed there, as you can see, in conducting the study. Next slide. Okay, the materials continued. Next slide. Okay, the study design and the population. So this is the 3-month study. It's a cross-sectional observational study, and it was carried out at the labor ward, a maternity theater of Aminu Kano Teaching Hospital, Kano, and also at the Department of Microbiology of Bayero University, Kano. The study population involves 82 babies who are made up of 50 babies born through spontaneous through SVD and 32 born through CS. Their ages are no more than 30 minutes before samples were collected. The inclusion criteria of these babies are that they must be born at the maternity ward or at the theater ward or maternity theater of Aminu Kano Teaching Hospital. And these babies must have received any form of ocular prophylaxis, no form of treatment after they were, and there will be no form of morbidity after when they were born. Babies will not become, babies that came out from outside, they were brought in, we are not accepted for the studies. Next slide. So, hard method. So, we did the test by collecting samples, gently rolling them across the conjunctival membrane of these babies. And once they were done, we labeled them serially as collected and then code them in such a way that it will be easy to identify them. And then they will be stored in the refrigerator, and within 24 hours, they will move to the microbiology lab in ice pack containers in order to preserve the organisms so present in the swabs. And so when we get to the lab, the culture media was prepared. Blood agar was used as the culture media, which was prepared by mixing 0.5 ml of a blood serum in nutrient agar, 1,000 ml of nutrient agar, autoclaved, and then poured into culture plates, which when it solidifies, divided into 4 quadrants, and then each sample is now swabbed at each of these quadrants. After that, it was anaerobically incubated at 7 degrees centigrade for 24 hours, after which we took note of the growth organisms present. Next slide. Then after that, it's a process of identification of these isolates. So this is done by using the gram-stain method. And at the end of the whole process, because of time, next slide, please. Next slide. Next slide, please. Continue. Next slide. So at the end of all this, we went for characterization of the isolates. We noted after identifying the organisms, we noted them, then we want to now characterize them. Characterizing them means to be able to identify these isolates at the species level, because it will be a mixture of similar organisms. So be able to identify this organism is a particular this organism, we need to characterize them. And we did that using a biochemical test known as the IMVIC test, which stands for Indo Methyl Red Voges Proscore test and citrate utilization tests. So at the end of this, we're able to now isolate and say for sure this is the particular organism we are dealing with. And so we recorded all the tests and observed and recorded them. The next test. So the next stage will be to do the sensitization profiling. Next slide, please. And so we did that using the disk diffusion method. So by this organism that I've already isolated, we now smeared them into a Mueller-Hinton agar already prepared, and then placed a paper disc containing 9 antibiotics in the surface of the culture plates, and then incubated them again at 7 degrees for 24 hours. And then at the end, we looked at the character of the sensitivity of how they responded. Those were sensitive, those were resistant. We looked at them and we took note of them, recorded them as observed. Next slide. So the data was analyzed using SPSS